Hi everyone, I'm Dr. Wumi. Welcome to our first episode of Healthy You with Dr. Wumi podcast, where we'll be having real honest conversations about health topics that matters most. In today's episode, we have a seasoned expert to answer our most pressing questions on perimenopause. Dr. Grant went to medical school at the University of Alberta and completed her family medicine residency at Dalhousie University in Halifax. She currently practices as a family physician in Edmonton and spends part of her time at the menopause clinic at the Grey Nuns Hospital. She is also a Menopause Society certified practitioner since 2022. But beyond her impressive qualifications, she's passionate about helping women navigate the changes of midlife with confidence and compassion. And when she's not taking care of patients, you find her reading, dancing, or spending quality time with her kids. So grab your tea, settle in, and let's get into this unfiltered, empowering conversations about perimenopause. Let's get started. Welcome once again, Dr. Grant, to the first episode of Healthy with Dr. Omi podcast, and I'm excited about it. And so tell us, there are people out there that don't know anything about perimenopause. How will you explain perimenopause to someone that's out there and maybe hearing it for the first time, or they've even heard it but they don't know what it is?
Good question. To start off, I think it's helpful to talk about what menopause is. So menopause is defined as the period of time once you've gone at least 12 months since your final menstrual period. The period of time leading up to that is called perimenopause. And so perimenopause, if you're looking at someone who's having periods still, perimenopause starts when there's a change in the length of consecutive menstrual cycles, of them being shorter or longer by at least 7 days. In some cases, you can't rely on menstrual cycles to diagnose perimenopause. So for example, if someone has had a hysterectomy or if they're taking some form of birth control that suppresses their periods, then you can't really rely on periods to tell you when perimenopause is starting. So the most typical starting sign of it would be hot flashes or night sweats. And some of the less common symptoms could include things like muscle and joint aches, insomnia, mood changes, anxiety, vaginal dryness, urinary incontinence, or urinary frequency, which is going to the bathroom more often.
Okay, thank you. And so how can someone differentiate between normal stress and the start of this hormonal transition? Because everything just comes up. But for me personally, I found out that about a couple of years ago now, around my period, I become more, which wasn't like that before. I become more agitated. I become irritable. There was even a um, funny incident that happened. I was in the kitchen, and my son came close to me and said, "Mom, are you on your period?" And I asked why. He said he heard that it's when women are on their period that sometimes their mood changes. That was the first time I noticed that I was having mood changes around my period. And it was around that time my period started becoming irregular. So how can one really differentiate between normal stress and the start of this transition?
That can be difficult because sometimes both things can be going on at the same time. There might be, normal stress. A lot of women, when they're in perimenopause, they're in a phase of life when they might be taking care of their aging parents, but also still parenting their children. And, they're often at the peak of their careers. There can be so many causes of stress at that time. One thing that can be a clue is sort of as you described, where you maybe notice a change depending on the phase of your menstrual cycle that you're in. And many women who never really had any problems with premenstrual symptoms, suddenly they notice that leading up to their periods or during their periods, they are a little bit more moody or irritable or anxious. So if you're noticing a cyclical pattern like that, that can be a clue that maybe it's related to perimenopause, but there's no perfect way to know. There's no blood test that'll tell us that it's because of perimenopause and not because of stress, but that what's going on with your cycle can be a clue.
Okay, thank you. And that brings me to the next question. When I see some patients come in and say, "Oh, I think my hormones are not balanced. I need to do hormonal tests, and then there are perimenopausal symptoms. How, for those patients that want to have their hormones checked, or they're worried that, oh, if because of the hormonal fluctuations that they're having the symptoms and they're trying to fix their hormones, what will we tell them?
Yeah, so what I tell my patients is that in most cases, what's going on with their menstrual cycle and their symptoms will actually give me a lot more information than what any blood test could tell me. And especially in perimenopause, there can be a lot of fluctuations in hormone levels. So from one cycle to the next, you might go from having hormone levels that look postmenopausal to having the hormone levels of a 30-year-old woman. And so those hormone levels don't really tell us exactly what's going on. There may be some exceptions to that. So, in someone whose periods have become very infrequent or that have stopped altogether before age 45, or if we can't rely on bleeding because of hysterectomy or medications, then and they're under 45, that's when sometimes hormone levels might be helpful in figuring out what's going on.
Okay, thank you. So still talking about the regular cycles. Some women also, apart from their periods not having infrequent periods, lesser flow, some people experience heavy bleeding and they just say, oh, it's perimenopause. For those women experiencing heavy bleeding while going through the process, what advice would you give them?
Yeah, that's a good question. I think I would start by just giving some information on what I think heavy bleeding is, because a lot of women just get used to what's going on with their bodies and they don't really realize that what they're having is considered heavy bleeding. So some of the clues would be things like passing large blood clots that are bigger than the size of a quarter, having gushes of blood with standing up, leaking through menstrual products, or even another useful clue is just if you feel that your periods are too heavy, that's considered heavy bleeding. And that's a really important issue to actually deal with, because heavy bleeding can have a major impact on quality of life, but it can also really lower your iron levels, because if you're losing a lot of blood every month, it's impossible to really bring up your iron stores, and iron deficiency can actually lead to a lot of the same symptoms as perimenopause, especially fatigue and brain fog.
Thank you. And to what you've just said now, I find some patients coming in and saying, oh, my hair is thinning, I'm tired. Is it perimenopause or not? So from what you've said now, it could be due to the heavy bleeding that they are experiencing. Those are having every period. So what advice would you give them if they have the symptoms?
Yeah, so for my patients with heavy bleeding, there are a lot of approaches that can be taken. One simple approach that can be helpful for some people would be to take an anti-inflammatory medication on a regular basis throughout their period, something like ibuprofen, for example. That helps a little bit, but we do have some more effective options out there as well. Another medication that I'll sometimes prescribe in perimenopause is a pill called tranexamic acid. And that's something that just helps your body to build stronger blood clots in areas where you're having bleeding. And so that is a pill that's typically taken about 3 times a day for the first 5 days of a period. And that can drastically reduce the amount of blood loss. And then we also have some hormonal approaches that we can take, including things like birth control pills or a hormonal IUD. Those would be some of the most common treatments I would recommend for that.
Thank you. Is there a place for them? Maybe, is there anything that needs to be ruled out to be sure that, oh, this heavy bleeding is due to perimenopause, or there's something else going on in their womb?
And that's a good question. I would say if there's a really dramatic change from what the periods were like before in terms of how heavy they are or how long they're lasting, it might be helpful to talk to your doctor about getting a pelvic ultrasound and possibly another type of test called an endometrial biopsy, where a sample is taken of the tissue from inside the uterus. So that's what I would recommend if there's a change in your periods. Otherwise, in general, if I'm seeing someone whose periods are heavy and they're not improving with any of those treatments that I've recommended, that's another situation where I might recommend doing some of that testing.
Okay, thank you. So we'll go to one of the common symptoms of perimenopause, hot flushes and night sweats. What are the most effective natural or medical options for dealing with this? And how do you decide what is right for you as a person?
So that's a big question. It depends on a lot of factors. Some people might have health conditions that would have an impact on what might be recommended, or just personal preferences in terms of whether they prefer to manage things with or without medications. Often my approach is that if someone is having very severe or frequent hot flashes or night sweats, often I will recommend some kind of medication right at the beginning. For someone with milder symptoms, it may be beneficial to just try some simpler things first, just things like dressing in layers, trying to figure out if you have any specific triggers for your symptoms. So there isn't anything that I would say is a consistent trigger for every woman, but it's worth paying attention to whether you feel worse after having caffeine or alcohol or any other specific foods, and maybe trying to minimize those if that's an issue. There's been some research on whether things like yoga and exercise can be helpful for hot flashes and night sweats. And it turns out they don't really help with those symptoms, but they can still be beneficial for other reasons in perimenopause. So those are still things that I think are reasonable to try. Another very important factor is for anyone who's smoking, it can be really beneficial to quit smoking. Women who smoke tend to go through menopause a little bit earlier and have more severe symptoms compared to women who don't smoke. So trying to avoid smoking can be incredibly beneficial. And there are a couple of kind of unusual treatments you might not have heard about or wouldn't expect for this, but there's actually some evidence to say that clinical hypnosis can be helpful for hot flashes and night sweats, as well as a type of treatment called cognitive behavioral therapy. That's often used for treating some mental health conditions like depression or anxiety, but it is actually also beneficial for hot flashes and night sweats. And then besides all the things that I've just mentioned, some other things that can be helpful would then be medications, which we'll go through in a bit more detail later on, but that it could include things like menopausal hormone therapy or some non-hormonal medications.
So the next question is about sleep. For most women, going through perimenopause, sleep can be a battle. How exactly does perimenopause affect sleep?
The most common sleep change that I'll see with perimenopause would be that women find that they're starting to wake up more often throughout the night. Sometimes it will be for an obvious reason, which may or may not be related to perimenopause. So that could be things like waking up to go to the bathroom, or waking up because you're having night sweats. But a lot of women will actually find that they're waking up and there's really no obvious reason why it's happening. And they just say, I don't understand why I keep waking up throughout the whole night. And so that's the most common sleep-related change I'll see. The other important thing to know about sleep and perimenopause is that obstructive sleep apnea becomes more common in perimenopause. So it's worth also talking to your doctor about whether you have any risk factors for sleep apnea and getting tested for that if it's appropriate.
Thank you. And so what are the practical tips or treatment that really works to improve the quality of sleep?
Yeah, so, in some cases, if it's appropriate, menopausal hormone therapy might be very beneficial for that. But there are also some non-medication approaches that can be taken. Similar to how I was mentioning cognitive behavioral therapy to treat hot flashes and night sweats, there's also something called CBTI, which is cognitive behavioral therapy for insomnia. And this is a specific type of therapy that can really help you to address insomnia. And it's been found to actually be more effective than sleeping pills for treating insomnia. There's also a website that I really like for insomnia that's called mysleepwell.ca. It's a Canadian website out of Nova Scotia, and they have links to a lot of resources for CBTI, and they also have a really nice information sheet with some sleep tips. I have it in front of me and I'll maybe skim through some of the highlights there. So they recommend going to bed at the right time, meaning that if you go to bed and you're spending a lot of time lying awake, maybe you should try going to bed a little bit later. They also talk about something called the 20-minute rule. They don't want you to be looking at the clock, but if you estimate that you've been in bed for at least 20 minutes, you should then get out of bed for a little bit, do something relaxing, and then try going back to bed after that. They also recommend getting up at the same time every morning, even on weekends.
That might be difficult.
Yeah, that's a challenge. It's also helpful to minimize naps. If possible, avoid them completely. But if you really need to take a nap, try to limit to just a 20-minute power nap. It's also beneficial to spend less time in bed overall, because otherwise your brain will start to associate your bed with being awake. And you really want your brain to think, okay, when I'm in bed, I just need to be sleeping. They also have some interesting tips for distraction, including something called the grocery cart exercise, where you just use your imagination and pretend that you're just walking through your local grocery store and you're looking at everything in detail. And I think that would put a lot of people to sleep. They also have some tips on some relaxation techniques to try before going to bed. And also trying to worry less about your sleep. It's easy to get into a cycle of not sleeping and then worrying that you're not going to be able to function because you aren't sleeping enough. And then that just breaks up your sleep even more. So if you can really let go of that idea that, if I don't sleep well tonight, tomorrow is going to be ruined, that can actually really help you to sleep better. And the last suggestion that they have on their tip sheet is to be physically active during the day, but not too late in the day. And for those in our audience who are from Edmonton or the surrounding area, there is a great resource available for CBTI, that kind of cognitive behavioral therapy for insomnia that I was mentioning before. So there's a clinic in St. Albert called Full Circle Women's Clinic, and they have a doctor there who offers CBTI, and her sessions are covered by Alberta Health.
Oh, that's good to know. Yeah. So when you say not to be physically active too close to sleeping time, what time would you suggest?
That might be a little bit different from one person to the next. And, I realize that a lot of people have busy lives, and the only time that they can find to exercise is in the evening. And so, if you're finding that, the timing of your exercise doesn't interfere too much with your sleep, overall, I'd rather have you exercise in the evening, because that's better than nothing. But if you're noticing that there really is a big difference, and if you have the ability to shift your exercise timing in your schedule, I think it's worthwhile. I think you can start by experimenting with maybe, at least on weekends, doing some morning exercise and just seeing if that makes a difference in your sleep, to figure out if it's worthwhile for you to adjust that timing.
Thank you. Anything about screen and sleep?
Yeah, I generally recommend trying to avoid screen time for the last hour before going to bed. Again, that exact timing might vary a little bit from one person to the next, but if you can, really try to eliminate those screens. Just read an old-fashioned book after that.
So here's a common frustration we hear a lot. Why do so many women gain weight, even if their diet and exercise haven't changed? And what can realistically help?
This is a question that almost all of my patients ask me. I would say 95% of the referrals I receive will say, my patient's having this, and this symptom, and weight gain is almost always on that list. And the story that I hear over and over again is, I'm eating the same way I always have. My activity level is the same. Why am I gaining weight? And so first, I think it's worth talking to your doctor just to rule out a few non-menopause related things that could be contributing. So it's worth reviewing your list of medications that you take to see if any of them might be causing weight gain. And depending on other symptoms or risk factors you have, there might be a bit of blood work that could be useful, although in my experience, often that blood work doesn't end up showing any problems, but it still sometimes can. Unfortunately, most of the weight gain that actually occurs around perimenopause is not directly related to perimenopause and doesn't actually respond to hormone therapy. It is mostly just related to an age-related change in metabolism. And so what this means is that for women who choose to take hormone therapy for whatever reason, it's not actually very likely that they'll find it easier to lose weight, in the sense that it doesn't have a direct impact on their weight. That being said, there are some women who still do benefit from being treated with hormone therapy, because some women, they're maybe gaining weight partly because they're sleeping so poorly and they're having, so many hot flashes that they can't tolerate exercise, and they just don't feel well enough to make food the way that they might have done before. And so if you go from feeling absolutely terrible to feeling better, that can help with weight loss. And so that is sort of an indirect way that hormone therapy might help with that. But in most cases, just the same advice for weight management that would apply to anyone else would also apply in perimenopause.
I remember my own personal experience. I was, a couple of years ago, I was preparing for a friend's birthday, and I had already made my dress a couple of months before. So when the dress arrived, I tried to zip it up. I tucked in my belly. It couldn't go in. I had to ask my youngest to help me. And I thought about it that if I wear this dress to the party, I won't be able to eat. So I said, oh, let me lose some pounds and see if the dress will fit. And I did what I used to do normally to lose weight. And for about 4 weeks or 6 weeks, the scale didn't move by a decimal. So that was when I do, oh, this wouldn't work in middle age, perimenopause. So I had to take some other measures because it wasn't easy to lose the weight. The way, and I see a lot of women complain about it same way, that have doing the same things and the weight is not changing. So realistically, what are some of the things that can be done to lose this weight for people, women gaining weight during perimenopause? Because I also see a lot of my patients coming in frustrated and there's that fear there that, oh, my doctor would tell me that I should eat less and walk more, but I'm doing all these things, or they've had other doctors tell them that, and the weight is not going down. So what can women going through this realistically do?
And that's a huge challenge. I would say if it's available, it would be potentially helpful to meet with a dietitian or an exercise specialist, just some people who can help out. Locally in Edmonton, I know that we have a few multidisciplinary weight management clinics, and I do end up referring a lot of patients there because they can benefit from seeing a lot of different members of the team who can really help them a lot. In some cases, medications might be appropriate for that, but they're not right for everybody. So I recommend talking to your doctor if that's something you're considering. And also in some cases, surgery may be beneficial, but again, that will not apply to everyone, and it's worth talking to your doctor. The general tips that I tend to give people would be just make sure that you're actually eating enough. Try to aim for at least 1.2 to 1.6 grams of protein per kilogram of body weight per day, and make sure that you're getting enough fiber. And then in terms of exercise, besides just the weight management side of things, perimenopause is a time when we're also concerned about bone health. And so I generally recommend trying to do a mix of some cardio, doing strength training at least twice a week, and doing some kind of exercise that challenges your balance. And that might be mixed in. Like if you look at an exercise like a lunge, that's going to help with strength and balance at the same time. So you don't need to overwhelm yourself with that. See how you can combine some of these things. But you don't need to necessarily lift heavy weights, but are you challenging yourself with some of that strength training? That can make a difference. But keep in mind that if you're actually gaining muscle through your exercise, the number on the scale might not actually move, but you could still actually have some significant health benefits. And I think it's always a good thing to help your body get stronger, more mobile, and more functional.
Thank you. So there's something else that there's a lot of buzz around, bioidentical hormones. I see some of my patients come in and say, oh, it's natural. I want to try bioidentical hormones. What exactly are they? And how do they compare to the traditional hormone therapy? And are they safe?
Okay, so bioidentical is a marketing term, and it's used to describe compounded hormone therapy. And so a compounded hormone is when you're not getting just a Health Canada approved medication that's made by the drug company and sent to your pharmacy. Instead, the medication comes through a compounding pharmacy where they get a powdered version of the medication, and then they compound it into a pill or a cream or something like that. And so compounded hormone therapy is very common. It's generally found at private clinics where people pay a lot of money to get assessments and get prescriptions there. And what a lot of people don't know is that the compounded hormones they're getting, they're actually using exactly the same raw hormones that drug companies would be using to make their medications. So you're not actually getting anything that's more natural or safer. And these compounded hormones aren't well studied. We don't really know if people are actually getting consistent dosing or if they're going to be absorbing them well. At this point, compounded hormone therapy is not recommended by any of the major menopause or gynecology societies around the world. A common misconception as far as safety goes is if you filled a prescription for medication before, you might have gotten a package insert that came with it, and it gave you all kinds of terrifying warnings about the possible side effects of a medication. When you get a custom compounded medication, it doesn't come with that.
True.
So people naturally assume, well, this is
safe.
this is
It's
safe,
safe, yes.
and they don't realize that it's actually, you know, it can still have all the same risks and side effects. Now, one thing that people sometimes want is they want to take hormones that are chemically identical or similar to the hormones that their body would have made. And so if that is something that's important to you, it's worth knowing that most of the Health Canada approved menopausal hormone therapies actually are made the same as the hormones that your body makes. And in many cases, this might be the safest or best option for someone. There might be some situations though where it might actually be beneficial for someone to be on a synthetic hormone instead. But we do have many products available that are made with the same kind of estrogen and same kind of progesterone that your body would make.
Okay, thank you. So what's the role of, I see some of my patients on the bioidentical hormone taking testosterone, progesterone. Is there any role for testosterone, progesterone in perimenopause to help with the symptoms?
Okay, so as far as symptom management goes, the main hormone that we use the most in perimenopause and menopause is estrogen. Estrogen is going to be the hormone that tends to work the best for treating hot flashes and night sweats, as well as some of those secondary symptoms like insomnia or joint pain. Progesterone is often prescribed along with estrogen, but the main reason that it's prescribed is because if estrogen was given on its own, it could cause too much growth of the lining of the uterus, known as the endometrium, and that could lead to an increased risk of endometrial cancer. But the other hormone, progesterone, helps to block the effect of estrogen on the uterus, and so when estrogen and progesterone are taken together in appropriately matched doses, then there's no increase in that endometrial cancer risk compared to the baseline. There might be some situations where maybe someone has had a hysterectomy, so we're not worried about the growth of their endometrium, where we might still actually consider prescribing progesterone. It's not very common, but it might be used in some situations. For example, if someone has a history of endometriosis, or in some cases, there will be women who find that estrogen helps with some of their symptoms, but it doesn't help enough with sleep, and progesterone may be beneficial for that. I find that most of my patients who take progesterone find it helpful for their sleep, but it's not right for everybody. Some women find that they get really vivid dreams and disturbing nightmares, or they just feel too drowsy in the morning. So it's not always perfect. And so in someone who still needs a hormone to balance out the estrogen in their uterus, we do have some other options. And then as far as testosterone goes, if you look online or if you look at the website for some of those bioidentical hormone clinics, you might find dozens of reasons why it's being recommended. At this time, the only indication that actually has good evidence for prescribing testosterone in women is for treating symptoms related to low sex drive. All the other things that it gets promoted for, things like weight loss or cognitive symptoms, muscle strength, bone health, none of those have actually been proven, but there is actually some research going on this. So in Australia, they actually do have some government-approved forms of testosterone for women, and so that's a place where a lot of testosterone research is being done. If this is a topic that interests any of you, and if you're on social media, I would recommend looking up Professor Susan Davis. She's an endocrinologist in Australia who conducts a lot of the research on testosterone, and she gives a lot of updates on some of the research that she's actively doing. So it's possible that if you were to ask me the same question 5 or 10 years from now, I might be able to give you more reasons why I would recommend testosterone, but at this time, low sex drive would be the only one. And even then, it's definitely not a black and white situation where you could say it's definitely going to help, because there can be so many other factors. And like any medication, testosterone can have some side effects.
Thank you. And that brings us to the next question about intimacy and vaginal health. How does perimenopause affect libido and vaginal discomfort? And what are some solutions that work without shame or stigma?
So I think the first thing that's really important with this question is just to normalize differences in libido. So a lot of men might experience what's known as spontaneous libido, which would be just where they might just randomly think about sex and be interested and turned on right away. For women, that can be the case, but it's more common to actually have a responsive libido, which means that you're not really interested until you get started. And so a lot of women will say, I'm never the one who wants to initiate sex, but once I get started, I actually do enjoy it. So that will often be the case, but there may be many reasons in perimenopause why it might not be enjoyable. And so it's really important to address some of those factors. The most common one is a condition known as genitourinary syndrome of menopause, which is just a fancy term for all the different symptoms affecting the vulva, the vagina, and the bladder that can be caused by menopause. And so one of the most common symptoms would be vaginal dryness, along with pain with sex. And we know that statistically about 80% of women will develop genitourinary syndrome of menopause at some point. And once you have it, it is a chronic condition. So it's not just going to go away on its own over time. So it's very important to get that treated. In some cases, women will do okay just with some over-the-counter treatments, like using a lubricant as needed for intercourse, or there are some vaginal moisturizers that are used on a regular basis. Think of them kind of like putting lotion on your hands in the winter. You need to do it every day to maintain the results. So for mild symptoms, those can be great, but in many cases, women do really benefit from using some local vaginal hormone therapy. And this is just where a very low dose of usually estrogen is applied directly into the vagina. And so it's just absorbed locally. As long as it's the right dose, it's not going to impact the level of estrogen in the bloodstream. So it's very safe as far as side effects or risks go. So in general, vaginal estrogen, if it's working well, can be continued long term. Another factor that could be affecting libido would be hot flashes, night sweats, mood changes, and sleep disturbances. So, if any of those areas are a big concern, it can be worthwhile to treat them, whether that's with hormone therapy or non-hormonal medications.
Okay, thank you. And that brings us to the next question. What role can hormone replacement therapy play in managing symptoms? That's the first part. And how do women know if it is right or safe for them personally?
So, menopausal hormone therapy is the most effective treatment that we have for hot flashes and night sweats. And so for most women, as long as they don't have any kind of health condition that would make it unsafe, it will usually be my first recommended treatment option for them. If someone has a health condition that would make it unsafe, or if she's looking at starting treatment over age 60 or more than 10 years after the last period, then I would recommend using something non-hormonal instead. But for most women who are perimenopausal and they are under age 60 and less than 10 years from their last period, then menopausal hormone therapy would be appropriate. In some cases, let's say someone is still perimenopausal, a birth control pill might be used instead. And the reasons why I might choose that would be if someone is having irregular or heavy periods, or if contraception is still needed. Now, menopausal hormone therapy is sort of similar to birth control pills in terms of who can and can't take it, but it isn't exactly the same. Okay. So just as an example, if someone has high blood pressure, it's generally not safe to take a birth control pill, but it actually can be safe to be on menopausal hormone therapy.
Sorry if I may ask, sorry to cut you short, why is it safer? Is it because of the concentration of the components, or why is it safer for someone with high blood pressure that is perimenopausal to take hormone replacement therapy than the birth control pills?
Yeah, good question. So it's based on a few factors. One is that menopausal hormone therapy uses much lower doses of hormones. And then also it can be given in different ways where it's metabolized a little bit differently. So with a birth control pill, the estrogen gets metabolized by the liver and it can increase levels of some of the clotting factors in the blood. But with menopausal hormone therapy, we have ways of being able to administer it through the skin in the form of a gel or a patch. And when estrogen is given that way, it doesn't pass through the liver when you first absorb it, and so you don't actually increase the levels of those clotting factors.
Thank you. So when it now comes to the different types of hormone replacement therapy, which one has the least side effect, if there's anything like that, or which formulation it's more tolerable, if there's anything like that?
Yeah, and that would depend a little bit on a lot of individual factors, but my approach is usually to try to find the lowest dose that works well. Now, there might be some exceptions to that. If we're talking about someone who is under age 45, I'm often going with higher doses, but usually for women 45 or older who are perimenopausal, I would just start low and then build up as tolerated. Often I do find that the gels and patches are better tolerated than the pills, and that might just be because you get steadier levels of estrogen when it's given that way, and so you're not experiencing quite as many hormone fluctuations. And then from the progesterone side of things, that generally the one that I'll start with would be just a medication called micronized progesterone, and I find that most women tolerate that one well. That's the one that's the same as the progesterone that our bodies make. But I might switch someone over to a synthetic progestin or use a progesterone-containing IUD instead for someone who's having side effects from progesterone.
Thank you. And so what are some of the side effects of hormone replacement therapy, or are there no side effects?
I wish. Yeah, so there are some side effects. Most of these side effects are going to happen in the first few weeks, and they'll often settle over time. But they could include things like headaches, nausea, breast tenderness, and bloating. I would say those are the most common ones that I see. If I have someone who's starting estrogen and progesterone, I'll sometimes have them stagger the start dates by about 2 weeks. Maybe start the estrogen first, add the progesterone a couple weeks later. That way, if they are having side effects, it's easier to know which one is causing the problem.
Thank you. Are there people that hormone replacement therapy are contraindicated? Are there people that can't take hormone replacement therapy that it's contraindicated in them? And if that is that case, are there non-hormone replacement therapy options for people like that?
Yeah. So some people who can't take hormone therapy would be people who've had a heart attack or they've had a stroke. Most people who've had a history of a deep vein thrombosis or a pulmonary embolism, which would be a blood clot in the leg or the lung. In most cases, they can't take it, but there might be some exceptions. In that case, usually a hematologist who specializes in blood clots would need to give an opinion on that. It also shouldn't be used in people who have a personal history of breast cancer or other estrogen-sensitive cancers. Note that I said personal history, though, and not family history. It's a common misconception.
Please, can you explain that more? Because some people say, oh, my mom has had breast cancer, my sister has had breast cancer, I cannot take hormone replacement therapy. Please, can you clarify that?
Yeah. So there are some studies giving what we call observational evidence, meaning so these aren't randomized controlled trials, but it's still studies comparing groups of people. And what they've found is that women who have a family history of breast cancer, if they go on hormone therapy, that isn't going to further increase their risk above where it already is. So we know that their family history already does make them high risk, but adding on hormone therapy isn't going to make a big enough difference above that risk for it to be important. That being said, I think, if someone has that kind of family history and is reluctant to take hormone therapy, I certainly wouldn't force it on them. But for someone who is interested in it, I think it's worth knowing that, yes, it actually can be quite safe, but it would be important to keep up with routine screening.
So I have patients come in and say, oh, don't talk to me about hormone replacement therapy, especially those that are having significant symptoms. Are there non-hormone replacement therapy options for managing perimenopausal symptoms?
Yeah. So we're lucky that we're starting to get more non-hormonal medications to use. It used to be quite common to use a medication called clonidine, which was an old blood pressure medication. That one is starting to fall out of favor in a lot of the menopause guidelines because compared to the other options, it tends to be less effective and more likely to cause side effects. I've come across a few patients who were already on it before seeing me, and when they stopped it, they did find that their symptoms came back. But most of the time, I don't find it all that helpful. We do have some other non-hormonal medications that were also developed for unrelated reasons, but that happen to help with hot flashes and night sweats. This would include many types of antidepressants, a medication called gabapentin, which is sometimes used to treat different types of pain or seizure disorders, as well as a medication called oxybutynin, which was developed for treating overactive bladder. Now, besides all those medications, we do finally have a medication available in Canada that was actually developed specifically for treating vasomotor symptoms, which are hot flashes and night sweats. So this is a medication called fezolinetant, or the brand name is Veoza, and this one actually targets the part of the hypothalamus that helps with temperature regulation.
Wow.
And so the neurons there normally get blocked by estrogen, but when you take estrogen away, they become more active and they trigger more hot flashes. And this medication actually does help to block that. So it's really directly targeting where the problem is coming from. And so this is safe for people who can't take estrogen or don't want to take estrogen. It's more effective than all of our other non-hormonal options. And we've just had it available in Canadian pharmacies since March of this year.
That's great. That's good news. There are also some people that say, "Oh, I'm a natural person. I do natural. I don't want to take hormone replacement therapy. I don't want to take any non-hormone replacement. I just want to do it natural." Are there supplements or natural things that can help control the symptoms of perimenopause, especially the hot flashes and night sweats, or the other symptoms too?
Yeah, so there are a lot of options out there that people try. Unfortunately, most of them haven't really been studied all that well, or the ones that have been studied have had kind of inconsistent results. So there's nothing out there that I can say, here's a supplement that is going to help. One of the types of supplements that's had at least mixed results, where in some studies it seemed to help, were certain types of soy supplements. But that's something where it might actually depend a little bit on the population and what someone's soy intake was actually like when they were younger. So that won't consistently help everybody. Another medication that I'll commonly see, or a supplement I'll commonly see, would be that people will take black cohosh, but that one, its studies have not found it to be helpful, and there's actually potentially a risk of it being harmful to the liver. And there are many other supplements out there that we could say similar things, where we just don't actually know if they work and we don't know enough about their safety. One natural approach, though, that actually does have a little bit of evidence is just eating more vegetables in general. That has actually been found to be helpful. So if you have someone who really doesn't want to take anything, but they're really motivated to try other things, increasing their vegetable intake might actually be helpful.
Oh, that's good to know. What of evening primrose? Or I've heard people make a 3 evening primrose. Does it have a role? Do they have a role in managing perimenopausal symptoms?
Yeah, so those also don't have good evidence.
Okay.
Yeah.
Okay. Thank you. And we'll soon round up. Let's talk about bone health, because it's usually overlooked in conversations, in early conversations, in people that have going through perimenopause. What can women do now to protect their bones and reduce the risk of osteoporosis later on? It's because we know that with decline in estrogen, the bones get thinner. So when a woman is in perimenopause stage, what can they do to help to protect their bone health?
Okay. So there are a lot of lifestyle things that it can actually make a really big difference for bone health. And so that would include trying to minimize alcohol intake and avoid smoking.
Sorry, please, I'll stop you there a bit.
Yeah.
What is minimized alcohol intake? What's the average alcohol? Because some people say, "Oh, I don't drink, but I keep my drink till the weekend and I have all my drink together." So what is safe drinking, or the recommended amount of alcohol that adults should take, especially women maybe or men in the midlife period?
And that's kind of hard. It depends a little bit on which specific outcome you're looking at. The guideline that I often aim for when it's realistic is I say try to aim to stay under 2 drinks a week.
Yeah.
But I know that's not going to happen for everybody.
Yes.
And it hasn't been all that long since we used to have Health Canada guidelines saying that women
true.
should have up to 10 drinks per week. And I just tell women it's kind of on a gradient. We just know that the more you drink, the more health risks there can be. And so I don't think there's a level where we can say, above this, you definitely won't have problems, or above this level, you definitely will have these health problems, and below it, you won't. It's just a spectrum there.
Okay, thank you.
Yeah. So yeah, back to bone health. So minimizing alcohol, avoiding smoking, making sure you're getting enough calcium. So before menopause, the recommendation from Health Canada is for women to get about 1,000 milligrams of calcium per day. And then in perimenopause and postmenopause, it's recommended to aim for about 1,200 milligrams. And that can come all from the diet, but a lot of women have trouble getting that much calcium from their food alone. And so that might mean adding in a little bit of a supplement. Okay. And there's a great tool if you're trying to figure out if you're getting enough calcium. So if you go to the Osteoporosis Canada website, they have a tool called the calcium calculator where you can enter in what you might eat or drink in a typical day, and it will calculate for you how much calcium you're getting.
Nice.
And let you know if you need to add on a supplement. In addition to calcium, I generally recommend that women take about 1,000 to 2,000 international units of vitamin D per day. And then the final thing that in lifestyle-wise, that's often helpful for bone health would be exercise. As I alluded to before, the biggest factors for bone health would be strength training exercise as well as balance exercise. And on the Osteoporosis Canada website, they have a section called Too Fit to Fracture that has a lot of great ideas for exercise. Besides all those lifestyle factors, in some cases, medications might also be appropriate for bone health. So if it's appropriate, that might include things like a birth control pill or menopausal hormone therapy, or sometimes specific osteoporosis medications.
Thank you. So to wrap up on an empowering note, what are the most impactful lifestyle changes, like exercise, diet, supplement, or even mindset, that can help women thrive and not survive in perimenopause?
Okay, so I think the key things that every woman can try to do would be, avoid smoking, minimize alcohol intake, try to exercise on a regular basis, see if you can try something new or find something fun to do. We were talking before recording this about how I've started doing some beginner dance classes, and that's really brought a lot of joy to my exercise. And then I think it's also actually important to just try to have a positive attitude towards aging and not try to prevent everything age-related that's going to happen. I haven't looked into this in detail, but I did hear on one of the medical podcasts that I listen to that research has shown that people who have a positive attitude towards aging actually live longer.
Yeah. And for myself, I tell myself, I might be 50, over 50, but my mind, everything about me is a 25-year-old girl. So, that kind of makes me, even though my back is telling me, oh, your back is sore, is feeling like a 70-year-old, but that positive mindset really, really is very important.
So the menopause clinic where I work is at the Grey Nuns Hospital in Edmonton. And on my team there, I have a fantastic health educator, and she offers menopause education sessions a couple of times a month over Zoom. And you don't need to be a patient of our clinic to go there. You don't need a referral for the class. You can just call the menopause clinic and sign up. So if you just look us up online, search for the Grey Nuns Menopause Clinic education class, there's a number that you can call to sign up for the next education session.
And that brings us to the end of today's episode, Perimenopause Unfiltered, expert answers to your most pressing questions. A huge thank you to Dr. Alexandra Grant for sharing her wisdom, compassion, and practical guidance with us today. I know so many of you are walking through the season feeling confused or even alone, but I hope this conversation reminded you that you are not alone and you are not powerless. Perimenopause is not the end of your vibrancy. It's a transition, and with the right knowledge and support, you can move through it feeling informed, confident, and whole. If this episode helped you, please share with a friend, leave a review, and don't forget to subscribe to you'll never miss an episode of Healthy You with Dr. Wumi. Until next time, take care of your body, nourish your mind, and show yourself grace in every season. You're worth it.